Hello, everybody. My name is Connor Lynch, the Director of Original Content with Westwood Media Center. We are proud to be partnering with the Westwood Council on Aging to provide virtual programming through our cable channels and online to keep seniors engaged throughout the coronavirus pandemic. We can be found on Comcast channels 8 and 12, Verizon's channel 32 and 42, as well as online at westwoodmediacenter.tv. I'm happy to turn things over to your host, the Director of the Council on Aging, Lena Arena DeRosa. Lena, take it away.
Thank you, Connor. As always, first and foremost, thank you to Westwood Media. We could not continue to grow and to reach out to our seniors without you. So always thank you. And hello, my seniors. It's good to see you again. I hope that you are all staying safe. You're wearing your masks, you're doing social distancing, and I hope you are well. If you need us, always remember we're still here at the center, even though we're closed to the public. Today, we're going to be speaking to Eddie Martucci, who we love, who you have had lunch, who we've hosted lunch and learns with before this whole pandemic. He is from Big Y. He's a pharmacist. Hello, Eddie. Welcome.
Hi, Lena.
It is so weird to do everything through Zoom, but we are doing everything through Zoom now. Let me give you a little, I know. So let me give you a little background about Eddie, and then I'll hand it right over to Eddie. Eddie graduated from the University of Connecticut with a BS in pharmacy and a minor in economics in 1983. He has a PhD in the Doctor of Pharmacy, and he got that in 1992. He is certified in talking about diabetics, asthma, vaccinations, as well as medication therapy management. He has owned his own pharmacy for many years, and then he moved to Walpole in 2017. And for the last few years, he has been the pharmacist manager at several Big Y pharmacies and wellness centers. Welcome. We're so glad to have you, Eddie. I'm so grateful that you're going to be talking about COVID-19, the seasonal flu, and other viruses that can affect us all. Take it over, Eddie.
Thank you, Lena, and thank you once again for the opportunity to be able to speak to our seniors in Westwood about this. We did do a lot of lunch and learns, and I do have to give you credit that it was you who coined the term of lunch and learn, and I think it's a phenomenal term. And unfortunately, I have stolen that and used it for several different other towns in the area. My talk today is COVID-19, seasonal flu, and other cross-species viruses. What is COVID-19? COVID-19 is a virus that affects us. It is designated severe acute respiratory syndrome coronavirus number 2. So SARS-CoV-2, which is synonymous to COVID-19. It is a coronavirus, and the reason it's named a coronavirus is because it looks like it has little crowns on it when we look at it under an electron microscope. The naming guidelines that happened with the CDC in 2015 name these viruses now to not recommend or not to refer to a geographical area, a source of where they came from, or for people who have been primarily affected by it. So that's why we have SARS-CoV-2. The coronavirus is part of COVID-19 is a coronavirus. It's also zoonotic, which means it comes into humans through an animal. Its incubation period is about 6.4 days. It's an extremely virulent virus. 2 to 3 people become infected if they come in contact with one person who has COVID-19, whereas with the seasonal flu, it's less than 1-to-1 infection rate. It's a single-stranded RNA virus. It's spread through droplets that gets into the infected host through eyes, nose, or mouth contact. It's very similar to a MERS virus or a regular SARS virus. And it's a very cold weather virus, which means it proliferates better in cold weather. 2 reasons for that. It just likes the cold better. And then in the cold, humans' defense systems are not what they used to be. Our cilia in our nose aren't as active. Our nasal passages aren't as moist to help protect us against viruses coming in. As I mentioned before, SARS and MERS were other viruses that the COVID-19 is similar to. Severe acute respiratory syndrome for SARS, and MERS is Middle Eastern respiratory syndrome. The very first SARS virus, which happened in 2002 to 2003 in China, came from a civet cat, which looks like kind of a cute little animal, but may not be. Has some little devil in him there, if you see the picture. MERS came from the camel, and our COVID-19 came from the bat. MERS was in 2012, mostly in Saudi Arabia, and the MERS, the SARS virus COVID-2, which is our COVID-19, happened in Wuhan, China. The symptoms that were happening for stage 1, which originally were designated, were fever, cough, and fatigue, and you see the percentages there in the presenting people with the infection. Sore throat, increased sputum, comiza, which means that our nasal passages are a little swollen, and myalgias, which are aches and pains. Those new symptoms that are down in red on the screen were something that was designated through all of the work that the health organizations have done since May. So chills, loss of smell, and anorexia are also now new stage 1 symptoms of COVID-19. Stage 2 symptoms are severe cough, dyspnea, which means we have trouble breathing, hypoxemia, which means that our blood oxygen level goes down, respiratory distress, and respiratory failure. In the middle of all these stage 2 symptoms, at the pharmacy level, the retail pharmacy level, we were having a run on pulse oximeters, which measures our oxygen level, because people wanted to know if they were COVID-19 without going outside to have a test. So the biggest question is, who's at risk for getting COVID-19? COVID-19 affects 2 to 3 times more adults than children. The risk groups are those of age 65 or older, and those of age 80 or older in a nursing home have an even greater risk of becoming COVID-19 positive. Those people with heart disease, respiratory disease, or diabetes, people who are immunocompromised are also at risk. The next few groups are added in May, as they had added the first stage 1 symptoms in May. Those are people with a body mass index of greater than 40, people who are HIV positive, people who are homeless and in low-income situations, people with cancer, kidney, and liver disease. BMI stands for the body mass index, and if you're over 40, you are considered obese. We as humans are considered obese. The World Health Organization got involved, and they had some strategies to try to limit the spread of COVID-19. They wanted to interrupt human-to-human interactions. They wanted to identify, isolate, and care for those people that are COVID positive. They wanted to decrease the exposure of new people to get COVID by finding out where the source came from. They also want to communicate to the world critical event information and critical risk information. And they wanted to decrease the social and economic disruption of this virus. I put a little timeline together, and I slanted it towards Massachusetts because we live here in the Commonwealth, so I thought that was more appropriate for us. In December of 2019, China announced that they had a severe pneumonia outbreak in Wuhan province. Just a month later, the World Health Organization declared that it was a public health emergency. 28 days go by and we have 80,000 confirmed cases, which is a huge number in just 1 month. In 10 more days, on March 10th, we had 113,000 cases with 4,000 deaths. And as you see, most of those occurred in China. On March 11th, the World Health Organization then declared a global pandemic. Massachusetts, as well as the rest of the United States, mandated shelter in place in April. And then we started opening up again in May. And stage 1 opening occurred May 1st. And because this pharmacist enjoys golfing, I put down that we were allowed to golf again. Stage 2 opening happened in June, and in July, stage 3 opening. And in the beginning of this month, August 3rd, the governor announced the safe travel states, which means that you don't have to shelter in place for 14 days. You don't have to get a COVID test to prove that you're COVID negative to go back to work and to get back into the public. And those states are the New England states and New York and New Jersey. Now, our little sister, Rhode Island, is, I don't know if she's a bad stepsister or not. I love Rhode Island, but she seems to go on and off our list for how high her spikes are. We can talk a few seconds about the spikes while I put this slide up, just to show how important it was to shelter in place. When you have signs coming into a major metropolis in the United States that say you have to shelter in place, it shows that the pandemic was real and that it was meant to be taken seriously. Some of the reasons that we have spikes now is that our testing is a little bit flawed to the positive, meaning that maybe we overestimate the number of people that are COVID positive, but that's not really a bad thing because we're being more cautious because it is very virulent. So if I were to go get a test and I became COVID positive, I have to wait for 3 more days to get a COVID negative test to go back to work. If I went back in 3 days and I was positive again, they count that as a second positive test instead of counting me as the same person. So there are good things and bad things about that. The reason we did shelter in place was to decrease and interrupt human-to-human contact. We wanted to limit travel. They recommended that one family member do the grocery shopping or the mandatory shopping that you needed to do. Or if you had to go out of the house, those things that you had to do. Social distancing was something that was mandated and recommended to stay 6 feet apart. And that's because the virus is spread by droplets. Want you to wear a mask that covers your nose and mouth. And I know that's very difficult. We wear one every day, all day at the pharmacy. And there are times when our staff has to go into a place of private to take the mask off just to breathe a little easier. It's more difficult with people who have asthma and other respiratory diseases. They want you to limit touching your eyes, nose, and mouth. So we did things when we got together like elbow bumps and air hugs. We do FaceTime and Zoom and virtual parties and celebrations. And I know we did several Zoom pizza parties on Sunday nights with my children, my wife and I and my children, where we all made different pizzas and then talked about it. And that's what this new world is coming to. But we want to stay safe, and that's very, very important. One of the most important things that we can do is to sanitize and disinfect. And we see the various pictures that designate that. Now, if my pharmacy shelves always looked like that bottom right-hand corner, I would have been a very popular pharmacy destination to have that much sanitizer throughout the whole pandemic. Effective agents are soap and water. Soap inactivates the virus, water washes it off of our skin. The recommended time for washing our hands is 20 seconds. And singing the happy birthday song out loud or to yourself twice is 20 seconds. My wife always recommends that I sing it to myself because we're never going to have Motown want to record this singing voice. One of the best examples that I've had, though, of how well you want to wash your hands after you've made contact with somebody you don't normally have contact with, or you've been out in the world for a little while, is imagine that you've made salsa and you've cut up a nice, juicy jalapeno pepper, and now you want to insert your contact lenses. How well do you want to wash your fingers to make sure that you don't get that jalapeno juice in your eyes? That was one of the best examples I've heard of how well you want to wash your hands. 75% alcohol, whether ethyl isopropyl works, hydrogen peroxide works. And so in the cleaning products that are out there, Clorox, Pine Sol, Lysol, whether they're in a spray disinfectant form or whether they're in wipes, are also very effective at killing COVID-19. Agents that are not effective that people have tried. Vinegar is not really working. Ammonia doesn't work. And burning sage helps to kill bacteria in the air, but it doesn't do much for viruses that are out there. They've also used heat products, and people have tried to put things in the oven and in the microwave because things that are sterilized are autoclaved, but we have to remember that those are under 7 times the pressure of a normal room, and the autoclaves get up to about 275 degrees. We really don't have things in our home that can get that hot. One of the best scientific places where we found that we can find what kills bacteria is Reader's Digest. That was a little facetious on scientific. That actually came from the University of Connecticut's research on what is best for the public. But Reader's Digest, and you can see the email or the web address there, has a really good website about what kills bacteria and what kills viruses. Some of the products that we use every day were tested to see how long a viable COVID-19 virus would be alive on that material. So tissue paper, it only lives for 3 hours on tissue paper. That's why one of the biggest recommendations for the non-spread of COVID-19 is to throw your tissues away immediately. Don't reuse them. I know many of us wipe our nose, wipe our mouth, and then put the tissue back in our pocket, and that's really not recommended in this day. Wooden cloth, you can see, is 2 days. Some of the longest is copper, and on cash, it can last 4 days. So another recommendation is to use your ATM card or credit card. And I'm not trying to plug Visa or MasterCard or American Express. They probably would be happy to hear that, but It's one of the better ways to make sure you're not touching something that somebody else touched. We can talk a little bit about medications that have been tried for COVID-19. I know that we have had a lot of talk about hydroxychloroquine in the media as something that stops you from getting COVID-19 or deactivates COVID-19. And that came from a small study in France that was done with people who were hospitalized. They needed respiratory intervention. And they used two different small groups. And it really wasn't scientifically done, but in one group of 20, they gave them the hydroxychloroquine and azithromycin after they were off ventilators. And in another group of 9, they got no medications. 6 days later, 13 of the 20 had no trace of the COVID-19 virus. And in the non-medication group, 2 of 9 had no trace of the COVID virus. But it wasn't clinically significant enough to do that. The reason that we're talking about respiratory intervention is that one of the worst things with COVID-19 is that 20% of the people who get COVID-19 need hospitalization and need respiratory intervention. And that was a huge crunch in the United States and in Italy that we saw in March and April of this year, because there just weren't enough ventilators around. So hydroxychloroquine and azithromycin really doesn't work. Hydroxychloroquine, the drug is normally meant for people who've had malaria, people who have lupus, or people who have an autoimmune disease like rheumatoid arthritis. And azithromycin, I'm sure many of us have heard of. It is a respiratory antibiotic that they use when you're having some respiratory infections. Some of the drugs that are used in the hospital, and these are mostly done through IV, that have shown promise and have worked are remdesivir and dexamethasone. Remdesivir is an antiviral drug that's normally used in HIV, and dexamethasone is a steroid that helps us with inflammation. Now, if we didn't need any oxygen therapy while we were hospitalized, remdesivir seemed to do the best. If we needed non-invasive oxygenation, which means that we had a nasal cannula for oxygen or we had an oxygen mask, then both drugs seem to work best. And if we had invasive oxygen therapy where they had to oxygenate our lung tissues directly, then the dexamethasone was the best drug used. Now, they've tried the remdesivir in 5 to 9 day trials to see what the difference was. There was no difference in cure rate. So they went with 5 days as the recommended dosage. If you're hospitalized, the FDA and the CDC and the federal government has stepped up and put into place emergency measures that medication is covered if you're hospitalized, and you need to get that medication because it's $2,340 for a 5 day course of therapy. So the government has actually stepped in and done a great job to make sure our people stay protected. I want to talk a little bit about the vaccine for COVID-19. Is there a vaccine? Well, not yet. Operation Warp Speed was put into place to bring drugs to market quicker than they normally were. And because of Operation Warp Speed, we have 3 medications that are in or going into stage 3 human clinical trials very soon. Moderna, the company in Cambridge, Mass, where the vaccine was actually produced in our neighboring town of Norwood, designated NA1273, went into stage 3 clinical trials in July of this year. AstraZeneca has one that's going into clinical trials this month, actually in 2 days. And Pfizer-BioNTech is September of this year. We're waiting to see how effective they are, what they're going to do, how they're going to work. As with any vaccine, I believe in vaccinations and I believe in herd immunity, but we also have to see how these vaccines are going to work in the general public before we can say, let's rush out and get the COVID-19 virus vaccine. That probably won't be available for use in the general public until September of 2021. They were trying to shoot for January of 2021, but I don't think that will happen. One of the other interesting information that came out from people being hospitalized and the data being collected was blood type differentials. And in all the people that were tested, it seemed that people who had type A blood cells or type A blood were more at risk of getting the virus or had more instances of being infected with COVID-19. People who were O positive had less. Now, does that really mean that those people protects you? They don't have any real studies because you're really not going to infect anybody with COVID-19. And what the blood types mean quickly is that if you are A blood type, you have the A antigen on your blood cells. If you're a B blood type, you have the B antigen. AB, you have both antigens, and O, you have none of the antigens. Now, just so that you know, some of the other people in the animal world that, well, they're not people, animals in the animal world that share these same blood types are apes, gorillas, bonobos, and rats also have the same blood types that we do. That's why a lot of rats are done in studies for medications, because many of their organs and internal systems work the same as humans. With flu season coming up, the biggest question is, should you get your seasonal flu vaccine? And that is a resounding yes, you should get your seasonal flu vaccine. This pharmacist believes in herd immunity, as I mentioned. Herd immunity means that if you vaccinate 95% of the population against a certain disease, it no longer exists. So I believe in that, and I do a lot of vaccines at the Big Y Pharmacy in Walpole. We are putting together safe ways to be able to do our vaccinations. We've been doing some Shingrix clinics where we have people come in, take the paperwork, we get their cell phone number, they take the clipboard out to the car with them, and these clipboards and pens have been sterilized before they're given to the patients. They fill it out, and when everything is all ready for them, they're called in, they ring up the register in 30 seconds, they come into the room, and we vaccinate as quickly and efficiently as possible. To talk about the new flu vaccines, the seasonal flu vaccines change every year. And there are two ways that they are made. There's actually three ways, but only one company does cell-mediated or the RNA recombinant vaccines. And most of them do chicken egg vaccines. That's why they ask you if you're allergic to chickens or eggs when you go in to get your flu vaccine. And the egg-mediated vaccines are now quadrivalent, which means they have 4 different strains. The 2 A strains are both from China. Guangdong and Maowan is the first one, and Hong Kong. The 2 B strains this year one of them has changed. It's Washington State, which is where they had a big outbreak of COVID-19 early on in February because of those cruise ships that came in that were infected. And then Phuket, which is in the Philippines. The cell-mediated and RNA-mediated changed the Guangdong to Hawaii's virus, but the other 3 do stay the same. The only difference now in the high-dose senior vaccine, which I know we are getting in by the end of this month, is that it's now a little more vaccine to be injected. It used to be 1/2 milliliter, it's now 3/4 milliliter. And they find that the larger volume gives a better antigenic response for those of us over 65. I wanted to put in a slide about some of the notable pandemics. You can see that our SARS-CoV-2 or COVID-19 virus has infected over 21.5 million people. These numbers were as of Sunday night, so they might have increased a little bit, but these numbers are as of Sunday night, with 760,000 deaths for a fatality rate of 3.6%. You can see Ebola was much more virulent, but it wasn't as spread as much. The SARS virus that we spoke about earlier that happened in China in 2002 and 2003 had a 9% death rate. The Spanish flu, which happened a century ago, killed 10% of the people. And that just shows you that 500 million people were infected because we couldn't stop the spread of the disease. And even the swine flu in 2009 and 2010 infected over 60 million people. That being said, at this time in our life globally, we were able to prevent the spread of this virus that could have killed many, many more people. If we had the same type of spread as the Spanish flu, we would have had over 23 million deaths in the world. And if we had the swine flu, we would have had over 2.5 million deaths. So we did a really good job at preventing the spread of this disease. The conclusions to my talk today would be to keep your social distancing, keep 6 feet apart if you can, wear your face masks that cover your nose and your mouth, and to wash your hands. And as another conclusion that's not on there, get your flu vaccine this season. The recommended time for flu vaccination is for healthy individuals of any age to get their vaccination from second week of October to the second week of November. Those of us who are over 65 that have some underlying health disease, specifically respiratory disease or heart disease or diabetes, are recommended to get it at the end of September. And those recommendations are still in place. They are being talked about. Should we get it earlier? Should we not get it earlier? I have seen and done vaccinations when I was in Connecticut with the Big Y at people at risk who were over 80 that had 2 or 3 underlying diseases. I would give them a vaccination early in September, and then I would give them another vaccination in January. Check with your doctors, please, to check to see if that's something that they want you to do, but please get your seasonal flu vaccine. We'd like to open this up now to Lena with some questions. What kind of questions do we have?
So I do have a few questions, and thank you.
Absolutely.
Yeah, this was fantastic. So if you do get COVID-19, can you get it again?
You can get it again, just like any other virus or bacteria infection. Your body certainly can get it again. Normally, when we get a virus or a bacteria, our body identifies it as non-self, and we make antibodies to fight that antigen. So we can do that, but it doesn't mean it happens again. We can take the biggest example is shingles. People have gotten shingles multiple times. People who've even got the vaccine can get shingles. If you do the shingles, the new Shingrix vaccine that's out there, if you do their protocol, your first vaccination, your second vaccination in 2 to 6 months, you are 97% protected, but there's still a 3% chance you may get shingles.
Okay, so I wear a cloth mask everywhere I go. I hope you all do. But how should I clean it, and how often should I clean it?
The recommendations, of course, come from the CDC, and that would be to wash it every day, and washing it in your regular wash.
Okay.
Washing it with soap and water, that certainly would work. Is that really feasible? Probably not. It's very difficult for somebody to always wash their masks every day, unless you have a 14-day supply, then, as often as you do your wash. Personally, I wear one for 2 days and then I wash it. So that is the way it is. Now, that being said, there can be viable COVID-19 viruses on the outside of your mask for up to 4 days. So you may want to take that, but washing it in soap and water that you do in your washing machine with hot water would certainly be enough.
I want to let the
I almost was a joker this morning, Lena, and I almost wore my mask on.
I want to let the seniors know that if they would like some cloth masks, we do have a number of them here. They can call us and we can get it out to them. So please, if you need more masks or if you need a new one, let us know. We have homemade ones here.
Before I got my cloth masks, just to interject, I apologize for interrupting. I was wearing surgical masks, and we do have those too at the pharmacy. They come in a box of 50. They're less than 50 cents a piece. And I would wear a surgical mask and throw it away that day. And so that's another option.
Good information. And you have a pretty big supply at the Big Y.
We have a large supply right next to the pharmacy at Big Y. If you're looking at our pharmacy to the right, we have shelving that a whole full shelf, 6-foot shelf is covered with boxes of masks.
Great. So one of the things that actually interests me, which I didn't know, COVID is weather. In the winter we will get more COVID. The virus will come back. Can you just?
Yes.
I didn't know there'd be a spike in the winter. I mean, like you hear about it, you hear it's coming back in the fall, but
it's a cold weather virus. It survives better in cold weather, and it also because our defenses are not as great in cold weather. That's why many people get seasonal colds and seasonal flus, because our defense mechanisms, especially through our respiratory tract, through our eyes, nose, and mouth, are not as well. Our eyes are drier in the winter, so that the waterworks that happen when something gets in our eyes doesn't always happen. Our noses don't flush things out as quickly. And so the spikes that we saw in the southern states this summer, which were kind of contradictory to that, were not because it is not a cold weather virus and that it's adapted to live in the hot weather. It's because they opened things up in those states. So instead of people being outside in 100-degree weather with the hot sun, they were inside, and they were tucked in air-conditioned places, in bars and venues for dance and being close together. So that's where that spike came from.
And then just a minute on the seasonal flu. I know that Big Y and Walpole, when will you get your vaccine? We highly recommend that everybody get their vaccine sooner than later. Can you speak to that a little bit?
Certainly. I actually have over 60 doses of the standard quadrivalent flu in stock right now. I should be getting, I was promised 70 doses of the high dose for those of us that are over 65 years old. I still recommend the time frame. The optimum time frame is the second week of October to the second week of November. And the reason I do that here in our Commonwealth is because 5 years ago, we did have a large spike at the end of February. So if you get it too early in September, you're not going to be covered at the end of February. But I would certainly recommend the first or second week of October to get your vaccination.
Fantastic. Didn't know that either. Okay, you wanted to put in a few more slides. Would you like to do that now?
Sure.
And then I will thank you. So I know you have a few extra slides, Eddie. So let's see.
Let me pop those up for you. Get rid of our question slide. This is just a map of COVID-19 infection in the United States. I don't want anybody to get complacent and think that we're safe now, that we're over the hump. We are over the hump. But you can see the darker red are those states that are most infected. And as we get to the whites, the white doesn't mean nothing. White means that it's at least 50,000 people were infected. So you can see that there are still a lot of places in the United States that have COVID-19 or had a lot of COVID-19. And if you look at Massachusetts, we are one of those nice bright crimson red. So we are in the second highest group. So we don't want to be complacent with that. So please, social distance. Don't gather together with large groups. Do it socially. Do it through Zoom. Do it through virtual meetings. Wear your mask. Cover your nose and mouth. And please wash your hands. Get that stuff done. This is a new world that we're beginning to come into. And we have to find new ways to interact with each other. We can do it. We have to do it together.
Thank you, pharmacist Eddie Martucci. I cannot thank you enough. Big Y in Walpole is blessed to have you, and we are blessed to have you part of our team. Thank you again for joining us today. And we look forward to, maybe we can do this again in November or December and do an update. What do you think? All right,
Absolutely.
Great. Thanks again, Eddie. Be safe.
Thank you again for the opportunity.
Be
Stay safe, Lena.
Yep, right back to you. Bye.
Bye-bye.